Hi, my name is Erin Zeis, and this is my project, Statin Therapy as Primary Prevention in Patients Living with HIV. According to the Center for Disease Control and Prevention, in 2021, 1.2 million people were reported to be living with HIV in the United States. Of those 1.2 million people, 32,000 of those were newly diagnosed cases in 2021. HIV attacks the body systemically, specifically destroying CD4 cells, leaving the host susceptible to opportunistic infections. HIV also causes systemic inflammation throughout the body. The average time between acquiring HIV and diagnosis is an average of 3 years. That time frame is slightly shorter for population of men who have sex with men and longer for those who have heterosexual relationships but engage in HIV high-risk behavior such as IV drug use. With cardiovascular disease risk, HIV has never been a criterion for statin therapy or statin treatment until recently. Early HIV drugs were shown to increase a patient's cardiovascular risk due to the metabolic side effects of the drug. With HIV drug advancements, newer drugs do not contribute to the cardiovascular disease risk. Also, initiating HIV therapy regimen immediately after diagnosis can help reduce the cardiovascular damage caused by HIV-induced inflammation. However, even with initiating and adhering to an HIV therapy regimen, HIV patients are still at an increased risk of developing cardiovascular disease or suffering from a related event. Older guidelines assess the need for statin therapy through a patient's ASCVD or atherosclerotic cardiovascular disease risk, which is an algorithm that includes gender, age, race, total cholesterol, HDL cholesterol, diabetes, history, blood pressure, and smoking history. Through the years and evolution of HIV treatment, medications have been developed that contain fewer drug combinations that remain highly effective, more tolerable to the patient, and with fewer cardiovascular adverse effects, and can ultimately slow the HIV-induced inflammation. In healthcare, improving patient outcomes continues to be primary focus. Through continued learning and research, patient-centered care through nursing is ever evolving. The development of HIV therapy has continued to improve HIV care in the last 30 years. Through research, the previously mentioned guidelines, we've developed and tailored guidelines to HIV patients to improve the cardiovascular risk. And this scholarly project assessed the effectiveness of the newer guideline. Nursing is heavily research and patient-centered based. 5 patterns of knowing in nursing define how nurses learn and process the knowledge through empirics, personal, aesthetic, ethical, and emancipatory. Empiric knowledge is the most common knowledge we think of when learning, especially in science and nursing. It is the knowledge we gain through research and experiments. Throughout the years, we've learned and progressed on how HIV is treated, though providers should continue to counsel HIV patients on modifiable risk factors of cardiovascular disease. The inflammatory effect of HIV is a non-modifiable risk factor. Through research and empirical knowing, we have learned that initiation of statin therapy as primary prevention reduces the inflammation effects of HIV. Personal knowing a type of knowledge that comes from self-experiences and forms our thinking and values. It is essential to eliminate any bias when conducting research by discussing the new guidelines with all eligible patients with HIV, age 40 to 75, and recruiting all consenting patients of that population. Personal beliefs and biases are eliminated. Aesthetic knowledge is described as art through transformative acts. This type of knowledge comes from the way a nurse and patient interact with one another. The art in which a nurse presents educational information to their patients. In regards to statin therapy in HIV patients, the advanced practice nurse needs to discuss the guidelines and the research that supports initiating statin therapy with the patient in a way that the patient will receive the information. This too will allow the patient to verbalize any questions or concerns, giving the provider an opportunity to correct any misconceptions or unwarranted fears of statin therapy the patient may have. Ethical knowledge is applying one's moral code to decision-making within their healthcare practices. Withholding information from a patient would interfere with one's moral code or ethics. By discussing the effects that HIV inflammation has on the cardiovascular system and the new statin therapy guidelines, providers are presenting all information available to allow the patient to make an informed decision on statin therapy. Emancipatory knowledge is knowing social, cultural, and political differences and applying them to healthcare practice. African Americans make up the most significant percentage of people living with HIV, and they are also more likely to have cardiovascular risk factors and cardiovascular disease. Considering the racial disparities relating to cardiovascular disease and HIV, this group would especially benefit from primary prevention statin therapy. Significance for healthcare. According to the CDC, the average lifetime cost of HIV in the U.S. Is nearly $380,000. That was in 2022. The average yearly cost for a cardiovascular disease patient is $20,000. And the rate of cardiovascular disease in the U.S. is expected to double by 2035. Providers should continue to stress the importance of prevention of HIV through safe sex practices and avoiding IV drug use, and the importance of prevention of cardiovascular disease through smoking cessation, healthy diet, and active lifestyle. In addition to lifestyle modifications, preventative statin therapy can dramatically decrease the healthcare costs of the effects of HIV and cardiovascular disease. HIV also puts the host at risk for opportunistic infections, which can affect the patient's financial income. Absences from work often occur due to illnesses. Also, absences from work to attend the physician appointments and blood work to manage the HIV. Significance for the advanced practice nurse. Advanced practice nurses should continue learning through education and research. By adopting new guidelines and implementing statin therapy as primary prevention, the advanced practice nurse is adapting current practice to support current research and literature to improve patient outcomes and support patient-centered care. Through research and implementation of quality improvements, the nurse practitioner plays a critical role in leadership and as part of a team of physicians, nurse practitioners, registered nurses, pharmacists, and of course the patient. Through the review of literature, there were three major themes that I came across: risk factors, adherence, and outcomes. So first, there are many risk factors associated with cardiovascular disease and HIV. HIV itself is a chronic inflammatory disease that increases one's risk of cardiovascular disease. There's an average of 3 years from acquiring HIV to diagnosis, and an average of 7 to 8 years from primary HIV to AIDS without treatment, both of which can lead to irreversible liver damage. So achieving viral suppression as soon as possible after diagnosis is crucial, not only to control the virus, but also to prevent any further liver damage leading to HIV-associated hyperlipidemia, which in turn leads to cardiovascular disease. The cardiovascular disease risk increases with age and with advances in HIV therapy. People living with HIV are living longer and in turn are on HIV therapy for a longer period, which puts them at a greater risk for cardiovascular disease and related events. As people age, there tends to be a need for an increased number of daily medications or polypharmacy, which also can lead to cardiovascular disease. People living with HIV have a higher rate of comorbidities. Comorbidities increase the risk of cardiovascular disease and also creates the need for polypharmacy. Additionally, hypertension, elevated glucose or diabetes, and liver disease all have negative effects on dyslipidemia. As with all individuals, lifestyle modifications should be the priority in preventing cardiovascular disease. Poor diet, lack of physical activity, obesity, and tobacco use have been proven to cause cardiovascular disease and are more prevalent in people living with HIV. Medication adherence is a dreadful obstacle of statin therapy in this patient population for several reasons. People living with HIV take an average of 13 daily medications compared to only 6 in uninfected individuals. In one study I found in the literature, there was an increased non-adherence to statin therapy in this patient population of 40% due to doubting the necessity of treatment, since the short-term effects of dyslipidemia are difficult to prove to the patient. Drug-to-drug interactions is concerning with HIV therapy and statins. These interactions can cause adverse events and may also reduce the efficacy of HIV therapy. For these reasons, lower intensity statins are preferred for less drug-to-drug interaction potential. People living with HIV have increased poverty challenges, and the financial burden of additional medications may contribute to non-adherence as well. As far as outcomes, the cardiovascular disease continues to be the leading cause of morbidity and mortality in patients living with HIV and non-HIV patients. Although medication adherence is a barrier, statin therapy is significantly underutilized in those living with HIV. In the Reprieve trial that was done, it was shown that the use of pitavastatin in people living with HIV lowers the cardiovascular disease risk, event risk over a 5-year follow-up period compared to those who received the placebo. With pitavastatin, it was reported that cardiovascular events were 4.81 per 1,000 person years compared to 7.32 per 1,000 person years in the placebo group. Aside from reducing modifiable risk factors, statin therapy is the gold standard in the treatment and prevention of cardiovascular disease and related events. Statins reduce total cholesterol levels in people living with HIV comparable to cholesterol levels in non-HIV patients. According to Gene Watson's theory of human caring, the relationship between the nurse and patient is the backbone of the framework. Healing a patient begins with a solid relationship through trust and communication. This includes displaying kindness and communication, being available, active listening of both positive and negative expressions, and teaching. Treatment of the HIV-infected patient requires a strong professional relationship between healthcare provider and patient. One of the most challenging aspects of caring for people with HIV is medication adherence, as we've talked about. While on HIV therapy, patients feel healthy, leading them to discontinue medications. Inconsistent use of HIV therapy leads to mutations within the virus, making their HIV resistant to their current HIV therapy or their regimen. Building a trusting NP-to-patient relationship is vital to ensure the patient understands and believes and trusts the provider to put their individual needs in the forefront, which means taking daily medications that the patient may not feel is necessary. This is especially true when introducing a statin therapy to patients who are already experiencing polypharmacy. The theory of human caring to build a strong provider-to-patient relationship will be crucial when implementing statin therapy as primary prevention in people living with HIV. This quality improvement project used a retrospective chart review design to determine whether statin therapy reduces the risk of cardiovascular disease and associated events in people living with HIV. All patient identifiers were removed from the data collection sheet. All remaining data was then used. All remaining data that was used was entered into an Excel spreadsheet on a password-protected computer. After all data was collected from 50 qualifying electronic medical records, data was then sent to a statistician to be analyzed and determined whether the use of statin therapy was effective and statistically significant. The data for this project was extracted from the electronic medical records of 50 patients aged 40 to 75 years who had been diagnosed with HIV, who were currently on antiretroviral therapy and statin therapy, who were patients of the targeted infectious disease clinic. All genders and sexual orientations were included in the data collection. A letter of approval from the Maryville IRB and the infectious disease clinic was obtained for permission to release the electronic medical records of the adult patients who fell within the inclusion criteria who were patients of that clinic. So for our sample, the inclusion criteria included patient must be between 40 to 75 years of age. The EMR had a diagnosis of HIV. Each patient must be on an antiretroviral therapy regimen. Every patient must be on a statin medication. Every participant must be a patient of the infectious disease clinic. And the electronic medical record had documentation of reliable follow-up record with no more than 2 missed appointments in the last 1 year. The use of quantitative data was used to evaluate if statin therapy decreases the risk of cardiovascular disease and related events in this patient population. The de-identified nominal and scale data was then transcribed onto an Excel spreadsheet. The nominal data used included the statin drug the patient had been prescribed. All other collected data was scale or interval data of laboratory values. The nominal and interval data was then uploaded into SPSS software. A paired t-test was the intended test to analyze the data with one independent variable, which was the statin drug, and 2 or more independent variables, which was total cholesterol, LDL, and HDL. There was an improvement in the post-statin cholesterol levels when compared to the pre-statin cholesterol levels. The post-statin LDL levels were also showed an improvement when compared to the pre-statin LDL levels. These two results indicated that there was a statistical significance between the pre-statin and post-statin lab levels of the cholesterol and LDL. The paired t-test verified that statin therapy proved effective in decreasing cholesterol and LDL levels to improve cardiovascular health. Pre and post HDL levels were analyzed as well. On average, there was no major difference between pre-statin HDL compared to the post-statin HDLs. A Wilcoxon test indicated the findings to not be statistically significant. This study did reinforce the importance of prescribing statin therapy as primary prevention in this patient population because total cholesterol and LDL levels are the most compelling indicators of cardiovascular disease, as these two contribute to the buildup of plaque in the arteries of the body, while the HDL functions to remove excess LDL from the arteries. In summary, although the results of the HDL levels were not statistically significant, the statistical significance of the total cholesterol and LDL proves statin therapy is key in primary prevention in patients living with HIV aged 40 to 75 years. This just shows a project implementation timeline diagram. And these two bar graphs show the pre and post-statin LDL levels. The majority in the pre-statin were between probably, I guess, more 100 to 150. And then down here, the majority is from 50 to 100. Retrospective chart reviews have opportunity for project limitations such as missing data. This limitation was evident in the study as well. Reviewing the EMRs, there were many patients who had pre-statin lab levels, then were started on statin therapy, and repeat lipid levels were not ordered at the next follow-up appointment. Second limitation was the frequency of patients who were lost to care or had multiple missed follow-up appointments. Over the last 30 years, healthcare in the U.S. has made tremendous strides in advancements to improve care for HIV patients. The death rate from HIV alone has been cut in half in the last 15 years. In 2010, the death rate of HIV was 2.6 per 100,000, and by 2020, the death rate had dropped to 1.3 per 100,000. However, even with this drastic drop in the death rate, HIV numbers continue to climb due to non-adherence to HIV therapy, and one of the leading causes of death in HIV patients is cardiovascular disease and related events. There are clinical guidelines that are used in the treatment of HIV patients and the prevention of opportunistic infections. For example, in patients with a CD4 count of less than 100 or less than 200, a broad-spectrum antibiotic is prescribed to prevent opportunistic infections until the CD4 count has risen. The use of statin therapy as primary prevention in this patient population will become standard practice as well. For healthcare policy, despite the growing evidence that people living with HIV have a significantly higher risk of acquiring cardiovascular disease, current policies do not support the use of statin therapy as primary prevention. Current guidelines are based on traditional risk calculators, which consider age, race, gender, lipid levels, smoking history, and history of diabetes and hypertension. A diagnosis of HIV should be added to these risk calculators, or a new HIV-specific risk tool should be developed and integrated into electronic health record systems. For quality and safety, implementing statin therapy as primary prevention in people living with HIV supports a proactive and evidence-based approach to cardiovascular health and risk management. Initiating statin therapy in those living with HIV before a cardiovascular event occurs reduces hospitalization and improves life expectancy. Statins have long proven efficacy in lowering LDL and cholesterol levels and systemic inflammation, which are two key contributors to cardiovascular disease. Furthermore, tailoring statin therapy based on HIV specific risk ensures care is aligned with individual patient needs. Sustainability is how well an initiative may be adapted into practice and applied over a defined period of time. For a lot of providers, it takes several studies proving the same results to persuade a provider to adopt a new concept and apply it into their practice. This study has potential to be sustainable long-term. The infectious disease clinic, which the study took place, maintains a watchful eye on these studies and provides educational updates during mandated weekly meetings. It is notable that once providers adopt this new initiative, it quickly becomes standard in their practice and is offered to their patients who meet the criteria. Plan for dissemination. Evidence continues to show the benefits of using statin therapy as primary prevention in patients living with HIV. Tailoring current cardiovascular disease risk calculators to include the diagnosis of HIV would be helpful, would help identify the need of statin therapy in this patient population. Policy changes within health insurance should also be tailored to include statin coverage in people living with HIV. This project supported the use of statin therapy as primary prevention. People living with HIV are faced with a significantly higher risk of cardiovascular disease or related events due to the chronic systemic inflammation, antiretroviral therapy, and traditional risk factors. Despite ongoing strong evidence supporting the use of statin therapy as primary prevention in this population, statin therapy is often underutilized. This is due to many reasons, including outdated risk assessment tools and the lack of HIV-specific guidelines. Addressing these gaps through policy changes, updated protocols, and continued education for healthcare professionals who treat this patient population will lead to more consistent prescribing practices. Incorporating statin therapy as primary prevention into routine HIV care not only aligns with the national quality and safety goals, but also has the potential to decrease long-term morbidity and improve overall health outcomes for this high-risk population. Integrating HIV-specific cardiovascular risk tools and the use of statin therapy should be key elements of comprehensive HIV care. This is my slide for references, and that is my presentation. Thank you.